Hello and welcome to this video on understanding error in family medicine from RCSI Perdana, Department of Family Medicine. My name is Professor Anthony Cummins. The learning outcomes for this presentation are as follows. Having viewed this video, you should be able to outline the commonest causes of error in family medicine or general practice. You should be able to list the common heuristic biases that can occur when reaching a diagnosis. You should be able to outline a strategy for communicating with the patient following an error. In class, we will do this as a mock OSCE. Why diagnostic or other error in family medicine or primary care? Understanding medical errors is essential to inform or improve the quality of care delivery. GPs are the first point of contact, and certainly in the Irish and European models of primary care, they are the gatekeepers to secondary care. And if you look at the number of consultations occurring on a daily basis worldwide, 90% of all healthcare delivery occurs within primary care. As a result, error is more likely in family medicine because there's much more activity, much more diagnosis, many more referrals, much more prescribing done by comparison to other areas such as secondary care and tertiary care. The patients are increasingly more complex, partly because they're aging. They usually have multiple drugs and multiple illnesses. There are also more transitions of care, demands for referral, admission, etc. So the transitions of care are where particularly prescription errors occur in the transfer from GP to hospital, hospital back to GP, hospital to nursing home, etc. There is also more out-of-hours care. Certainly in the European model, unlike in Malaysia, the likelihood that a GP would be providing services 24 hours a day or even up to late at night is long gone. Most family medicine care occurs out of hours through designated out of hours teams. How is primary care or family medicine different to secondary care or hospital care? Well, first of all, the environment is different. There are different organizational structures and mode and site of delivery. A lot of care is delivered by telephone, by home visits, and increasingly by email and online. Primary care is much more accessible than secondary care. Patients can come and see the GP on the same day, for example. Majority of primary care services are now based on electronic health records. The consultations are different. The consultation times are much shorter than in secondary care, with an average of 10 minutes, although in Malaysia the average is about 3 minutes. The presentations are different. They are undifferentiated. When a patient is referred to a hospital clinic, the GP will have a specific diagnosis in mind and will focus on that, and in turn the hospital doctor will also focus on that. In primary care, the presentations are very undifferentiated and non-specific. There is also a lower prevalence of serious disease. Most people are not sick, whereas the prevalence of serious disease within a hospital population is significantly higher. The whole ethos of care is different, and this is something difficult for undergraduate medical students to grasp initially. Clinical uncertainty is the norm, and a lot of what we do as GPs is to reduce uncertainty, whereas at undergraduate level, and particularly having been exposed initially to hospital medicine, hospital surgery, you would probably have formed the impression that certainty is the norm. This is very different in primary care. You also have less access to investigations, as you're dealing with conditions in an early natural history, many of which will resolve completely spontaneously. There is probably less need for investigations. And because of the ease of access to see doctors in primary care, the relationship between the doctor and the patient is built up over numerous contexts. What about errors generally? Hospital care, about 98,000 deaths occur every year from avoidable errors in US hospital, and it is now recognized that prescription error is a significant cause, because of multi-morbidity and polypharmacy, a significant cause of not just hospitalization but also of death within the US. Within primary care, it is reckoned that there's up to 80 safety incidents or near misses per 100,000 consultations. The two most common causes of error in primary care are diagnosis and prescription error. Let's look at diagnosis first. The causes of this are usually multifactorial. One review in the US in the mid-2000s showed that there was an issue in the doctor-patient clinical encounter, about 78.9%. Some were patient-related factors, some were doctor-related factors. There were issues about late or non-referral and poor follow-up and tracking of diagnostic information. Again, one of the difficulties that may lead to diagnostic error in primary care is that the presentations are atypical often. So a patient may present with indigestion but actually have an acute myocardial infarction or a coronary event. The presentations may be non-specific. So, for example, fatigue may be the presentation and the sole presentation of underlying celiac disease. And major disease with a very low prevalence. For example, cough may be a feature of malignant mesothelioma, but there are far more common causes of cough in everyday general practice. Similarly, back pain in general practice is very common, but multiple myeloma as a cause of back pain is exceedingly rare. And again, it's important to focus on the increasing problems that are posed for doctors making diagnoses in primary care associated with multimorbidity of increasing complexity, polypharmacy, etc. This is an interesting slide from the work of Carl Hennigan and Paul Glasziou when they were at Oxford. It's looking at the stages of decision making in terms of making a diagnosis. So, for example, you may spot immediately what's wrong with the patient and label him as having had a stroke because of a hemiparesis or a herpes zoster because of the obvious rash, etc. Patients may diagnose themselves. Some doctors have a natural antipathy to this, but self-labeling can be very useful. There are other things also, pattern recognition. People with chest pain, an abnormal ECG, maybe a raised troponin. The diagnosis is fairly clear. We may use probabilistic reasoning, and we can also use clinical prediction rules in order to predict the diagnosis. For example, CRB65 for pneumonia, or for the sore throat, the modified Centaur score. At the end of the process, we may have a definite diagnosis, although in about 40% of cases in primary care there is no definitive diagnosis. So you may give a test of treatment, test of time in that you're fairly certain this diagnosis is not significant and not dangerous and should resolve spontaneously over time. So you'd arrange to review the patient in 2 weeks, by which time it should have resolved. It's important to give the patient a reasonable period of time here rather than bringing them back too early when you may be forced into a therapeutic decision that is really unnecessary. A test of treatment is where you feel almost certainly the diagnosis is, for example, esophageal reflux. But this is an otherwise healthy patient and young, and therefore there's no need to do endoscopy. You may give them treatment for, let's say, a 2-week period of a proton pump inhibitor and then review at 2 weeks, by which time this should be improving. You may find, as I said, in about 40% no label is applied, no firm diagnosis has been reached. But because of the easy accessibility to primary care, you can reassess the situation early. Let's look at a case history. A previously well 35-year-old woman attends you complaining of headache. The consultation, including history, examination and management plan, lasts about 10 minutes. Just reflect for a moment, what are the commonest causes of this presentation in this age group in primary care? What are the uncommon causes of the presentation? And how can you use discriminatory questions in your history taking to try to get the diagnosis correct? Let's look at some of these causes now. First of all, what percentage of patients who present with headache to the GP actually have an underlying serious pathology? 1 in 20, about 5%. The diagnosis is usually made on the history, as neurological signs are rare and a good history taking will usually elicit the most likely diagnosis. But in order to make sure that you have excluded the more severe presentations, certain discriminatory questions are important. So you may ask, is this the worst headache of your life? If the answer is yes, then you must consider the severe, potentially lethal causes of major headache, such as subarachnoid hemorrhage. You may then follow up with a question on whether this was of sudden onset and unprovoked. If the answer again is yes, then you certainly should be considering an intracerebral hemorrhage, a subarachnoid hemorrhage. If there are other symptoms, for example vomiting or fever, you may want to consider an alternative diagnosis such as meningitis or encephalitis. Let's dwell for a moment on two ways of thinking: intuitive thinking and analytical thinking. Here are 3 questions. You'll have 10 seconds only per question. Do not dwell on the matter. Write down your answer immediately. Here are the first question. A bat and a ball cost $1.10 in total. The bat cost $1 more than the ball. Here's your question. How much does the ball cost? Question 2. In a lake there's a patch of lily pads, and every day the patch doubles in size. If it takes 48 days for the patch to cover the entire lake, how long would it take for the patch to cover half the lake? Question 3. In a study of 1,000 people, among the participants there were 5 engineers and 955 lawyers. Jack is a randomly chosen participant of the study. He's 36 and somewhat introverted. He likes to spend his free time reading science fiction, buying gadgets, and writing computer programs. Which is most likely? Is Jack an engineer or is Jack a lawyer? Okay. The bat cost $1.05 and the ball cost 5 cents. It would take 47 days to cover half the lake. Jack is most likely a lawyer. Intuitive thinking is seductive. It's difficult to resist the first response that comes to your mind. In a study using these questions of 3,500 participants, only 17 got all 3 questions correct, 33% got all 3 incorrect. Now if you look and apply this to diagnostic error, the overall percentage of diagnoses that are deemed to be incorrect are about 15% on average in most studies. And we'd like to draw your attention to the work of Pat Crosscarry and his dual process cognitive theory. There's a video at the end of this, a link to a YouTube video at the end of this explaining this further. Effectively, the dual process theory looks at the interplay between intuitive thinking, which is automatic, seductive and fast, and analytical thinking, which is slower, boring and more deliberate. However, errors are more likely with intuitive thinking. Also, a mention of heuristics. This is important in how doctors make diagnoses. These are mental shortcuts that allow us to rapidly make decisions. Let's look at these in detail now. So at the initiation of the diagnosis, the doctor may be overconfident. He may overestimate their own diagnostic ability, including an over-reliance on gut instinct, which is intuitive thinking, and rely less on critically appraised evidence, or evidence that has been analyzed and therefore is more trustworthy. There's the concept of availability. In other words, rarer or less familiar diagnoses being missed because they may not be within your radar, within your thinking. And so your differential diagnosis may not be sufficiently wide to include these, even though the symptoms and signs may point in this direction. In the refinement of the diagnosis, there may be an issue with the process of anchoring, where some symptoms or physical signs are latched onto, and you sort of shoehorn these into the diagnosis. So the diagnosis that you have initially thought of through gut instinct, you will ignore subsequent information, which should prompt a recalculation of the entire diagnosis. But you latch onto this and stick with it. You're anchored to it. And in defining the final diagnosis, there may be a framing effect. The diagnosis will be impacted potentially badly, depending on the way in which the information provided is framed. You have to be careful not to make assumptions when others make suggestions. For example, nurses or GP colleagues, if they suggest an alternative diagnosis, you should be open to the suggestion. What about prescribing error? The annual prevalence in primary care is 5%, although there's work showing that in the elderly, potentially inappropriate prescribing or PIPs occur at a prevalence of about 36%. There may be two areas of error in prescribing error itself and monitoring error. So the wrong drug may be chosen. You may confuse carbamazepine, an anticonvulsant, with carbimazole, an antithyroid drug, the wrong dose, the so-called trailing zero. The patient may get 5 milligrams instead of 0.5 milligrams. That is 10 times the dose. You may give a prescription even though it's contraindicated. An example is HRT in breast cancer. You may ignore potential interactions, for example, warfarin and non-steroidal anti-inflammatories. Allergies may not be asked about or inquired about, or may be ignored when offered. There may be errors in monitoring. Failure to monitor patients on some drugs has more import than others. For example, methotrexate is potentially quite a toxic drug, although also quite effective, but it needs monitoring regularly every 2 months with full blood count and LFTs. L-thyroxine needs thyroid checks regularly. Statins need to have LFTs done pre-starting and during their usage, and also lipid levels for control. Occasionally you may need to check creatine kinase also. Warfarin clearly needs an INR. ACE inhibitors, ARBs, and also thiazide diuretics need electrolytes done fairly regularly. It's important for GPs to have built-in mechanisms of doing these, have call and recall systems so that patients are informed to come and have these bloods done. How do you communicate after an error? Well, it's clear that we need to change. There are various publications worldwide, these are just a few from the UK and Ireland, about the use of open disclosure. And this follows on from what's happened in the aviation industry, where near misses and major air accidents have reduced significantly through adopting a philosophy of open disclosure. Unfortunately, within medicine, this applies equally to Ireland and to Malaysia. There is often a blame culture, and therefore doctors who make errors are unlikely to disclose them for fear of the implications. In Ireland, the Commission on Patient Safety and Quality Assurance's report called Building a Culture of Patient Safety have suggested a culture of open disclosure, and more recently further guidelines from the Health Service Executive similarly. However, there is as yet no protective legislation currently, but this is imminent. What do patients want after an error has occurred? They want the truth. They want a truthful discussion. They want time to have the story heard and acknowledged, and they want information to the level of their satisfaction. Not doctors hiding behind medical jargon, but being truthful, honest, and consistent. They want an expression of regret or sorrow. This does not mean that you were liable, but you were genuinely sorry that this has happened. They want information on how such outcomes can be prevented in the future. And they don't just want an assurance, they want evidence that you're putting into place schemes within the practice that this will not happen again. They also want an agreed plan for ongoing care and for follow-up. And patients who do not receive all of this are unlikely to stay with the practice, more likely to take legal action, and not likely to remain your patient. On the other hand, an admission of sorrow, a clear, open and honest discussion is more likely to lead to the patient staying with you and continuing in your care. What about doctors' concerns after an error? Well, clearly there's a big fear of being sued and also suffering damage to their professional reputation. In the Irish healthcare system at the moment, this is particularly so, as most lawyers now advise patients to go directly to the medical counsel. And these complaints to the medical counsel are covered in the media, and therefore, even if a doctor has not committed an error, or the error of relatively minor import, it will be widely publicized. Excuse me. There may be difficulty for the doctor in working out exactly how much they contributed to the error. They're very concerned about their reactions of their patients and also managing their own emotions. There may be uncertainty about what exactly to say to the patient. It's interesting that in one study, 93%, virtually all doctors who were questioned, agreed that serious errors should be disclosed to patients, but almost equal number, 88%, believe that disclosing such an error would be very difficult because of the obvious implications of legal, etc. Okay. When we run this session in class, we will run an OSCE station looking at how you communicate after a medical error. So we will split a group of 12 into 3 groups of 4, and you have 4 scenarios, 1 scenario each, denoted by the letters A, B, C, or D. And you will also have 4 roles denoted by your number. 1 is the examiner, 2 the observer, 3 the patient, 4 is the GP. You'll have a 6-minute station, and then we'll have a group feedback. Now these are the roles. As the examiner, you have a sheet provided, and you should then grade the student according to the mark sheet. The observer also has a sheet to write down observations, particularly looking at verbal and non-verbal communication skills on behalf of the GP. The patient should read the scenario and then role play the 6-minute consultation, and similarly for the GP. Here's a model of how to manage the aftermath of medical error. This comes courtesy of the Medical Protection Society. And it's called the ASSIST model. The ASSIST standing for acknowledge, sorry, story, inquire, solution, and travel. So first of all, you should acknowledge what's happened. Say, for example, Mrs. Jones, as you know, there's been an error in your prescription. I can see you're upset and it must be very difficult for you. Then express sorrow. I'm very sorry you've had to suffer as a result of this. The patients want to be heard, so you may express this in a way such as, can you please tell me what happened in your own words? And how do you feel about what's happened? You may then offer them the option to ask questions. What questions would you like to ask? And also, there are a few things I think is important for you to know. You may then look for a solution, and this would be coming from the patient. You ask, have you thought about how we can best help you now? Or can I make some suggestions for you to consider? So when you've agreed what the patient wants to do, then you may finish by saying, well, it sounds like this might be the best way to go forward. The issue of travel is about whether the patient should travel as in move away from the practice or stay with you. If you've known this patient for some time, and this has been an incident for which you were sorry and apologize, then you should express that, because often patients feel abandoned when there's been an error. The doctors put up shutters and they're defensive and don't communicate. So I think you should express this by saying, I would like to continue caring for you and keep in close contact so I can ensure everything possible is done to help you. Now, if the patient is very angry and upset about what's happened, particularly if it's a diagnostic error of quite significance, then you have to allow them to exercise their right to move elsewhere and no longer be a patient of yours. Now, following that, we will swap roles and repeat the OSCE, now with the examiner being the observer and the patient being the GP. And again, we'll have group feedback at the end. Let's summarize. Delayed or misdiagnosis is the commonest cause of error in primary care. Understanding how errors occur is part of promoting patient safety. Effective communication following an error, though challenging, is an essential skill for all healthcare professionals. There are two YouTube videos here. One is a TED Talk by Brian Goldman, and the other one is on the dual cognitive process theory, intuition versus analytical thinking by Pat Crosscarry. They're both very instructive and well worth watching. They're both quite brief. This is a list of references for you to look up later. Thank you.